want to talk about why mothers should not die in Africa and Middle East, because that is where I have influence, and we sometimes, we have the same influence in some corners. So we will have this passionate discussion. Those one, it came at a wrong time, Christmas time, but it's a conversation that we need to start today.
So mine is basically just to welcome you, and as Mama said, today's discussion is very important. Her life matters, and everything regarding maternal death is quite important, especially being one of our mandates to ensure that we have zero maternal deaths throughout.
We need to look at the problems that we have. We need to see how we can actually put ourselves together, put the energy that we have, the resources that we have, even though they may be limited, to try and reduce our maternal mortality rate.
The most important aspect of UHC will be strengthening of primary health care so that, number one, the community health worker function and public health function become strong and functional again to enhance prevention of disease and promote wellness. Number two, at the dispensary and clinic levels, there is availability of basic diagnostic and treatment services. Number three, a functional referral system. For instance, people being seen at Kenyatta Hospital should be referred and not walk in for minor ailments. This means that doctors in both public and private facilities can deliver better based on their specialty, and therefore increase the chances of better outcomes and less deaths.
Unless you look at the mothers and babies dying, you will not be able to address quality improvement.
Maternal mortality is a big issue in this country, and people are very passionate about it. It has been falling over the years from about a high of about 520 deaths per 100,000 live births in 1998. Then to around 360 in 2010, and now it's about 342 in around 2017.
I shed tears. I cried because I cannot understand how in this era we can be talking about 9 out of 10 women who died in a health facility dying of poor quality of care. There are countries where a woman dies and people are in shock. It is in the news for days on end. There are people discussing how could we have lost a mother. Yeah, they know her by name, by age, where she came from. And I think as long as we keep banging our heads and having a discussion where we are sitting and drinking tea, we will continue to have maternal mortality.
99% of the world's maternal deaths, stillborns and neonatal deaths occur in low, middle income countries. To be precise, Africa and Asia. And in how many percent are preventable? 80%.
88.8% of women who died were young mothers aged below 20 years. I asked myself, among these, how many of the pregnancies were planned? 7 out of 10 births are not planned. I'm not an expert there, but I think it's true, because I've given birth to 3 children and none was planned. Imagine me. So I'm trying to think of my sister in the village. I think for it 100% unplanned. So I think the statistics must be true.
And yet we know that with the SDG goal number 3, we want to get maternal mortality down to around 70 per 100,000 live births. So we have a long way to go.
Why are these women dying? Whether they're the young teenagers, adolescents, especially the adolescents.
Because some of these deaths also occur because those under 20, most of them do not even go to the clinics as we had, and they are not tested even for the existing diseases. So something needs to be done about that.
Young women as young as 10 to 15 were telling us that they want information about issues like menstrual cramps, about contraceptives, about all that information that we're talking about. But what we do ourselves, we bury our heads in the sand and assume we cannot give them, they are still young. They don't want this information. Are they not the same ones who are coming to us with unsafe abortion?
I have seen parents, at a time like now, they are bringing their daughters who sat their KCP exams for implant. And yes, 14 years, and they are saying, I need an implant for 5 years. By the time it has expired, she has finished her Form 4. And when we say, can't we talk about this, they say, Madam, I have 3 older girls, and they all have children. They got children in primary school. This is my 4th one, and I know she's sexually active.
We are aware they're getting more and more sexually active at younger and younger ages. What is the NIDAS? Exposure. Because much as you have your baby in your household, they have exposures that are different. So the issue is, can we give information, give them choice, let them make informed choices, then provide that access. That's the order. Now, if you're just putting implants in this girl, I cry. Why? You're giving a method of family planning to protect from pregnancy. Are you preventing STIs and HIV? That's my bigger problem.
You know, whenever you talk about reproductive health, people think about contraceptives. They think about condoms. They think about their children. They don't know that it's a whole package. It's actually a whole life, especially of a woman. From before you're born to the time you're born, until you grow up, you become a grandmother, you still require the reproductive health care services. And ordinarily, when you sort out the man's reproductive health care services, it is reflected in the woman. So this is, you talk about a life for everybody.
You understand sometimes in this, even in the large hospitals in these countries, that the nurses are overwhelmed. I remember sometimes there will be so much pain, and you know the nurses have a record, they have a deadline on when they must do the recording, so sometimes a patient is crying in bed, but they are under this pressure.
That's the elephant in the room. How do I possibly monitor 15 women and I am alone on night shift? And not just in labor ward. I'm still seeing the woman who was admitted with an antenatal problem of draining. I'm still seeing the woman in labor. I'm still the one to check that they're all breastfeeding, those who have delivered and not developing PPH. That's the reality.
But when I went to India, something very interesting, occurred to me, that there are different categories of nurses. In the same hospital, there are nurses who will come and wash and clean the patient only. And there are nurses who, there is another category of nurses who then give out the medicine.
50% amongst the women who have died have been referred from another facility. So my lower level 3, level 4, tell you go to level 5, level 6.
These mothers who end up coming and losing their babies or losing themselves, dying, have actually trodden. They trod around the government institutions before they actually land into the right institution, which is, hence the data, level 4, 5, and 6.
So essentially, then all the mothers who, by the way, don't die in Pumwani and Kenyatta, they die in Mukuru, but we announce it in Pumwani and Kenyatta. So again, do we have a policy position, even the university, the academia, with regards to pushing highly qualified skill sets in as close as possible to the patient who's not at Kenyatta?
How active are we in surveilling those that die? Question mark. Do we get the report within 24 hours? At maximum 72 hours? Or are we ignoring it until 1 month is done? It may take even up to 3 days. The mother died a long time ago. Even as simple as what was her HB, blood level on admission. Did I get grouped and cross-matched blood to give the patient? She's dead before it gets there. So you implement solutions, but you must evaluate and refine.
And you realize that these women who die, will not only die because of maternal disease, they also have other diseases, right? They're adults, so there are many other things.
Let me tell you, ladies and gentlemen, because I also wear this other hat that's called medical litigation. And medical litigation are patients saying and demanding their rights. Are we clear? They ask questions nowadays. Why did it go wrong? Why? my patient die? Why did my baby die? And guess who they are looking at? The civic voices. And believe you me, it's not going to be business as usual for clinicians. You're being asked to be more accountable.
Once the cause of death has been established, the next thing is manner of death. So manner of death is a circumstantial statement, and as Professor Obena states, we use manner of death to determine what is the next downstream process for this particular mortality. Is it a case that requires further investigation through various medical legal routes? So if you classify it as natural, meaning that it's disease intrinsic to the individual, most of the time this is a case that we'll refer to preventive health, public health generally, to try and classify. If it's unnatural, meaning that the cause is external to that individual, then you have to subclassify it into 4 broad categories. Can be homicide. But when you cannot get pathology to describe the cause of death, then the next best thing to do is what? This verbal autopsy. So it's a system of classification of cause of death. Okay? And the idea is to obtain information from structured interviews by families, friends, caretakers of the deceased, and review of available medical records.
Now there's verbal autopsy and social autopsy. The two go together. Because unless you look at the social determinants behind every woman's death, was she illiterate? Was she educated? Did she have economic viability or not to be able to get services?
But the good thing about the verbal autopsy is that you can do it in all deaths. Okay, so it can have 100% coverage, and there are various groups that have used it widely.
Can we start by owning any near-miss, any maternal mortality, any stillbirth, and any neonatal mortality? That's all. Let's just say this one, it happened. Then it takes us to the next step of reviews and audits that are open, honest, where they're looking for solutions.
And I think one of the things we must aim to do is to make sure that each facility has an NPDSR team. I can probably say that for Kiambu Level 5, for example, we launched ours in June. We meet every month whether there's a maternal death or not, every third Wednesday of the month. I can probably say we sat down in June and agreed that we were not going to have a single preventable maternal death. For 6 months, we have not had even one. Our neonatal mortality has been the lowest since that NBU has been functional over the last 3 months. We recorded the lowest neonatal deaths in November, a single digit of 8. So I want to say that NPDSR works. We are documenting our best practices.
I congratulate Kiambu for them having no maternal death, but I used to be a chairman of Pumwani Maternity Hospital, and we saw our maternal death going down, and we were congratulating the staff and everybody. Then we discovered the patients who would have died in our hospital have gone on to die at Kenyatta National Hospital. So I think, Kiambu, you should find out, have you had any referrals? I'm sure you have.
I'm sure they have.
Kenyatta National Hospital, and what happened to those people you referred to the bigger hospitals?
If we want to move forward, let's go to the community. Empower the community, especially the mother who is becoming pregnant, because she will take responsibility of her own health, including pregnancy. There is another person we need to include in the knowledge. That is the husband, the mother-in-law, the auntie, because these people, especially some communities, they determine the way a pregnant mother is going to behave, is going where to deliver.
So even as we speak about free maternity care, beyond zero, all these many things that we have, can we take interest in who is this? Who is this who is dying?
Yeah.
Who is it? Any woman, 50, okay, in fact 10 to 55. We really should be taking interest. Why? Why has this person, were they pregnant? Was there anything beyond the normal that we could have done to change this narrative? But it is happening again because it is created in such a way that when we discuss the maternal death reviews at whichever level, the officers are discriminated. We talk different things other than reviewing what really led to the maternal death. And this is something that we can do at our own different levels to make sure that maternal deaths do not occur once they come to our hands.
We were told that patients are not paper. You cannot put them down and come and work on them tomorrow. They need you right now. I think we need to look at our policy, we need to look at our training, and we need to really look at policies allowing all these private hospitals to function within the community, really pretending to be giving healthcare and yet it is not healthcare, pretending to be helping mothers when they come to deliver and yet it is not care. The real issue here is the commitment.
It's leadership.
It is the commitment, and now the question comes: who should hold the people to account? Who should hold the CSs to account? Who should hold that minister to account? Who should hold the county chief officer to account?
Let's carefully decide on who should be in this committee. I was lucky to have worked in the UK where they started some of these things, the FEDSR systems. They ensure that they are independent. They ensure that the committee has no conflict of interest, and they ensure that the committee works on the principles of quality assurance.
I think we all need to agree that our mothers are not dying because there is nothing we can do. It's because we've not reached a point where we've decided that mothers' lives are worth saving.
Yes.
So we must agree that mothers' lives are worth saving and there's something that we can do.
Mrs. X died not because we did not know. And Mrs. X's or Mrs. they are still dying. And your last statement is where we need to reach. The society has not decided women's lives are worth saving. And I think she said it. My new advocacy expert, she said it is because the society, whether that society sits somewhere elitist, whether that society is with you down, the society has not decided.
Because health is key. We want it to be key issue. As we deal with manufacture, as we deal with the economic shared prosperity and others, health must remain paramount and must be the most important thing, because if you're not healthy, you will not be able to improve on your economic and political status.
We've talked enough. We need to actually advocate and go out there and hold these people responsible to accountability. You said this, you haven't done it, and these are the consequences. It's very good that we have teachers here who we need to work with to get to the young ladies, the young girls who are actually dying. It's disgusting. 56, 57 years after independence, we still don't have clean water in hospitals. We don't have clean toilets. We don't have sanitation. 57 years. I mean, it's a shame. But we need each other. We have to work together because every woman's life is worth saving. Thank you very much.